TopMedTalk.
We are here the evening of day 2 of EBPOM USA 2018 in Atlanta, and I'm sitting down with Monty Mythen, who is my co-host here on TopMedTalk, as well as Dr. Paul Wischmeyer, professor of anesthesiology and surgery at Duke Anesthesia, and we'll talk a little bit more about some of the other roles that he has there at Duke. Here at TopMedTalk, we've actually had several interviews with you in the last several months, and so we were just kind of wanting to catch up with you and see how things were and what's going on. Monty, you were talking about some of the other roles that Paul has played.
So Paul, we know each other well now.
We do.
In an adjunct position at Duke, I've visited a number of occasions.
Yeah.
One of the priority areas for TopMedTalk this year is the so-called opioid crisis.
Yeah.
We've heard lots of shocking stories, lots of issues about people walking away with large bags of OxyContin. You've experienced some of this personally.
So, it became very real to me even as early as 15. You know, the first time I got Demerol, which is how I was treated as a 15-year-old in the 80s, the birds sang, the heavens opened, flowers bloomed, I loved my mother, and all my troubles seemed to go away. And I vividly remember that experience. And at the end of all of the surgeries I had that year, I remember I'd been getting Demerol regularly, and they just came in and said, we're just going to stop it. And that evening, over about a 12-hour period, I felt something I'd never felt before, this incredible anxiety, which was not a word I knew at 15, and needing something, and that I would rather be dead than to feel this way. And I was withdrawing from opiates. But no one could tell me that. And so the surgeon said, maybe you're having sort of some issues with the pain meds, and we'll do a quick 3-4 day taper, and we'll just get you off. Well, they did that, and of course, as soon as they sent me home, this incredible anxiety came back. My parents didn't know what to do. They brought me back to the hospital. I was admitted to an inpatient adult psychiatric ward for seriously and sometimes criminally insane people in the inner city of Chicago, where I spent 2 weeks when all I was experiencing was opiate withdrawal. But they recognized it as some severe anxiety disorder I must have, put me on stelazine and other very powerful drugs. I slept under a ping pong table the first 3 nights because I was so terrified of the other adult patients in the unit at the time. And it was a locked unit. I couldn't leave, and my parents couldn't get me out. And so that was my first experience with it. And then, I guess the rest of my life, I knew this was an issue for me. And so I always had trouble getting off the opiates. But then it became very real in 2003, when now as a physician, an attending physician, I was having multiple dilations of a strictured stoma. And I would be written by my resident colleagues I was supervising for oxycodone, this new drug. And they would give me hundreds of them. And I would take them, and I was very stressed about the fact I was probably coming to surgery and I can't lose any more gut, or I'd be short bowel and needing TPN. And I would take them. And ultimately I did have surgery 3 times and was on 500 milligrams a day of oxycodone at that point. And I just want you to digest that for a second. 400 to 500 milligrams of oxycodone as a functioning, working physician. I was asked to come back to work by my chairman 2 weeks later on that much.
So for those people who may not be familiar with the drug and the doses, but give us some perspective on that. If I was hurting bad now and I needed a tab.
So the average dose, we would send someone out on 5 to 10 milligrams every 4 to 6 hours, so maybe 40 milligrams a day. So this is 10 times the typical dose that a patient would take because I'd been on it for so long. And my chair came to me on these doses about 2 weeks after my last surgery and said, we are down a liver transplant anesthesiologist because we had someone get called up to the military. Do you think you can work? And I said, I'm on 400 milligrams a day of oxy. Do you think that's okay? And he said, well, do you feel okay? And I said, I do. He's like, well, let's work on weaning you off. I guess one lesson is your colleagues and your chairman should never be your doctor. And he, who's I love him dearly, he was an outstanding chairman and an outstanding person, tried to get me off.
Yes.
And it wasn't happening. The withdrawal I would experience was debilitating to where, I would vomit and I would shake and I was non-functional. And I thought, well, I have to be able to work. So I have to take these drugs. And if I don't take these drugs, I'd get down to 100 and I could never get below that without severe withdrawal.
Were you addicted?
I was addicted. Clearly.
Did you know that you were
addicted? I absolutely did, but I didn't think there was anything anyone could do. It was like being possessed by a demon. And every day I'd swear, I'm not going to take these. But I couldn't go but 2 hours, and I would feel so terribly that I had to take them. And I actually imagined I would never again in my life ever feel normal. And that I'd always be possessed by this demon that could destroy my mind and my body, and I would never escape this.
Is that particular drug an issue here, or is it the the broad class of
It
drugs.
was pushed, I mean, for a long time.
Well, and it's the drug. I have to say, I've taken every kind of opiate there is, and that is unique. You know, I ultimately went to rehab for this, and I said, you know what, luckily my chairman came to me and said, Paul, you're struggling. Do you need help? And we have a wonderful physician health program in Colorado. Yeah. And they said, you're going to rehab. And I said, okay, well, can I go in a week? And they said, no, you're going tomorrow. Okay. And I spent 3.5 months in a physician rehab in Virginia. And it was one of the best things I ever did for myself. And they taught me how to get off these drugs. And I learned in there that if you're a heroin addict, because there were plenty of those too, the only drug they will take other than heroin is Oxy. Yes. It feels different. But what's different about it, too, is the withdrawal is immensely different.
Right.
I can take hydrocodone, I can take codeine, I can take even Dilaudid as a patient, and I can work my way off those. I was never going to work my way off Oxy without help.
It is
fundamentally that there is no reason anyone should get oxycodone for any reason but cancer and terminal pain. And I try to teach my residents that, but I watch them prescribe it for ortho patients and colorectal patients. We're devastating people because that drug causes withdrawal that is different.
Henry, you're a medical student. Where are you from, Henry?
I'm from Bristol University. I'm from London originally.
Okay, what stage are you at in your training?
So I'm a fourth-year medical student. I'm actually intercalating this year, so I've done 3 years, only 1 year in my clinical. I just wanted to ask, just so everyone knows, what kind of withdrawal symptoms were you seeing? Yeah.
It's overwhelming anxiety. Like, you are so anxious. You have such a need and such an overwhelm, you can't sleep. I went to Hawaii for 10 days thinking I'm going to go cold turkey it and I'm going to get better. I don't remember sleeping for 5 minutes of that 10 days, and I felt as bad on the 10th day as I did on the first day. It was never going to go away, I thought. And luckily, there are rehab programs that use tricks that I've now learned from my patients that no one teaches us with Ultram and Clonidine and Phenobarb. And Ultram is the be-all, end-all of getting off these drugs without suffering. And I use it every time I come out of surgery. My arm surgery, I'm taking it now to work. I just had a major arm surgery a few days ago. And had I not been worked off with this combination that rehab centers know and none of the rest of us are taught, and now there's publications jam on it, thankfully, but they weren't, I don't know that I ever would have gotten off.
So it's a real... this concern we have about opioids, in particular certain types of opioids, is a real issue. The other thing is awareness. We've had some discussions about this recently. Awareness for all of us. We've all got to look after each other. We're all at risk of this happening. Absolutely. We're all at risk of someone saying, take a couple of these, I'll help you sleep. Yep. If that does happen to us, we've got to be prepared to put our hands up and say, I need help. And that help has to come without criticism or blame, or it has to be supportive help, doesn't it?
And I think for the anesthesiologist in particular, this is the number one cause of death in anesthesiologists in the United States under 40. And it's true in other specialties as well. Cardiac surgery, nursing has issues with this. I was never judged. I was never threatened with my license. Yeah. I was never told they're going to take this away. The reality is we as our colleagues all see it in our colleagues.
Every day.
We know it's happening, and we're always afraid to tell anyone because we're afraid people will lose their jobs. You don't. Yeah. Most states in the U.S. and other places have protective mechanisms that if you're compliant with all of these interventions that the caregivers know how to do this, prescribe, you're not going to take your license. You're not going to lose your job. I didn't have any of those things ever put upon me as long as I was again compliant. Yeah. And I, of course, wanted to be. I didn't want to be possessed by a demon for the rest of my life that Oxy created.
Wellness programs and supportive programs that we can work together.
We have to report to our friends and to our colleagues when this is happening. People die. We had an anesthesiologist in my residency program die of propofol overdose. I discovered propofol is the fastest growing drug of abuse in our specialty. And Oxy has created a whole nother level of the patient addict.
I was just going to say the patient is the problem.
The patient is the problem.
We have support of our colleagues.
We have resources, but
patients do not.
We're creating this, and Oxy is unique. And I wish it would never be prescribed by my residents to anyone but the terminal cancer patient.
Henry, young medical students, for final thoughts?
Yeah, I mean, to be honest, for me, it sounds very similar to mental health as well. Very, very similar sort of pathway where a lot of people are scared to reach out and look for that support, and it's crucial within the profession that we are to get support when needed.
Desiree?
The problem is, again, we have support. We understand what all this means. We understand the pharmacology. I mean, we understand all those things. Patients do not. No. And what do we need to talk to our patients about? I mean, how do we have that conversation with them?
I think a key piece,
especially these chronic pain patients.
Yeah, and patients who've had major procedures or ICU stays. You know, I spoke for Wesley and Pratik. You know, they are very advocates of post-ICU care and post-hospital care. And they said the one novel thing that I said was patients after ICU and after big surgeries are all withdrawing.
Yeah.
If they're on
the
opiates
anxiety of all of it.
If they're on opiates more than 2 weeks, I can guarantee you they're withdrawing from these fentanyl drips and these oxys that we give them, and they suffer. And we don't address that with them. And we think somehow they're going to go home and they're going to figure this out on their own. I couldn't figure out it on my own as a trained clinical pharmacologist and anesthesiologist. I couldn't figure it out. So us being willing to say, you're likely to feel this way. This is what you're feeling. This anxiety is the withdrawal of these drugs. Here are the ways you can combat it. Using a little Ultram displaces the drug from its receptor, cuts the withdrawal without persisting the addiction and the withdrawal cycle. Little clonidine reduces the tachycardia and the anxiety also as well. And when it really gets bad, of course, you can use other adjuvants too, but honestly, Ultram is really the only thing I've ever needed since.
So, Paul, in our cohort of our critically ill patients from London, we reported about 50% of patients had post-traumatic stress disorder, what appeared to be, and anxiety was way up on the list. Do you think a lot of that is the withdrawal as opposed to the illness?
I think some of it is. I think, I think the PTSD and some of the other things are definitely real. Yeah. There's still things that create serious adversity to me to the point where I actually am rather pleasantly happy I'm not in the OR anymore because the smells, it's not the sights and the sounds, it's the smells of the OR, bring back all those memories of being a 15-year-old wheeling back to have sort of this life-threatening surgery done, and I still smell them when I walk through. They're triggers, and they trigger us. But I do think that benzo withdrawal is just as bad or worse. It can last for a month. I think all of these drugs cause this precipitous withdrawal that creates this incredible anxiety that leads to many people never being able to get out of it if they don't get help. Yes. And we don't ever address this as a possibility for them.
I think that as an organization and group, it's about for us too with patients withholding judgment.
Yes.
This
is a consequence of your care.
It is.
And addiction is a disease of the body.
It is.
Our brains, those of us that have been sadly through this, our brains are never going to be the same.
No.
You can do electron microscopy. On electron microscopy, the nerve fibers in the brain look different after exposure, especially as a child.
Yeah. Paul, thank you so much for sharing your story with us. I think it resonates with all of us as providers, as patients, and everyone in this space. Thank you so much.
Of course. It's important you're getting this message out.
It absolutely it is. And the discussion right now is so poignant for all of us across in the U.S. and abroad. So thank you so much.
You're welcome.
We are going to wrap things up for Day 2 at EBPOM USA 2018. Thank you.
Yeah.
Join us tomorrow.
Thank you.
And remember, you can join the TopMedTalk team live at one of our many broadcasts. Go to ebpom.org for more details. We're going to be in London on the 4th to the 6th of July for EBPOM in London 2018. Come along and see us. ebpom.org for more details.